So welcome to everybody. Thank you for joining us today at this event from PD project. These events are part of a series of webinars that will take place in the next few months and are organized by the PD project consortium. PD project is a project about palliative care in Parkinson's disease and is funded by the Horizon 2020 program of the European Union. We are very happy to start these events to communicate and spread the voice about the mission of the project. We are pleased to have today with us Professor Stefan Lorenz, an outstanding figure in the field of Parkinson's disease and palliative care. The focus of today's webinar will be managing common symptoms in the late-stage Parkinsonism. I will now give a brief introduction about our project. The PD project is still an ongoing project. We are still 9 months ahead before the end. We decided to focus this project on Parkinson's as it's one of the scenarios in which palliative care needs to be improved and spread. In fact, PD patients have considerable and mounting unmet physical, psychosocial, and spiritual needs that needs to be addressed. We have different barriers to be assessed and faced, and one of them is a linguistical barrier. In fact, palliative care is understood as synonymous to end-of-life and terminal care. Our overall mission is to validate a new model of palliative care that needs to be integrated in the current care and management of Parkinson's disease, especially in the late stage, by involving not only healthcare professionals, but also caregiver and patient. And with this webinar, our mission is now to pursue also an educational pathway to involve more and more students from healthcare professions to be familiar with this concept, that we believe it should be a pillar in the care pathway of patients. The PD consortium is composed by 7 partners from 7 different European countries. Our project was also recently joined by Region Skåne in Sweden. We have also a lot of partners like the European Association of Parkinson's Disease and other projects also funded by the European Commission, like iCare PD, who's also trying to improve care pathways for Parkinson's disease. The objectives we are trying to accomplish are to developing guidelines and recommendations to understand better when palliative care should be addressed and delivered. And we are also doing a clinical study to assess the importance and efficacy of delivering a community care based on a nurse intervention. A nurse intervention that will allow not only symptom control in the everyday life, but also will allow patients and caregivers to think about disease trajectories and course, and of course express also their wills. As I mentioned before, we have also an important activity that concerns the educational part, and we have started with the pilot phase of our massive online open course, which is available at our website. So if you go to pdpal.eu/MOOC, you will find additional information, and you're all invited to this preliminary phase of the course that will be launched in the next month. I want to thank again all the partners that are part of our project, and thanks again to the European Commission that is supporting us, and of course of the speaker we have today. So I will leave the stage to him, and I hope you all enjoy the webinar.
Okay. So I might now introduce myself. My name is Stefan Lorenz. I'm professor of neurology. I'm also professor of palliative care, and one of my specialties is palliative care for movement disorders. Today I want to give you a presentation about certain symptoms which are very important in the advanced and even in the late stage of these patients. And I hope you will learn something and hear something which you have never heard before. So I'm going to just open my presentation. All right. The title is the individualized care for patients. Actually, starting with a case report. I mean, you see on the left side, this is a PD patient, and he's the father of a very, very good school friend of mine. So I knew him and obviously my friend for more than 20, 30 years. From the first, Parkinson. I mean, at the time I was reporting now to you, he has been 72 years old and he had Parkinson's disease in 12 years. He was sent to a Parkinson rehabilitation, which in Germany is possible within the hospitals. Unfortunately, because they changed the medication, he developed psychosis. He has been transferred to the psychiatric hospitals, so they changed the therapy and he went back to the rehabilitation hospital. And during the rehabilitation, also because of the change of the therapy, he might develop the aspiration pneumonia. And the pneumonia has been so severe that he has been transferred to the intensive care unit. We didn't have to have him mechanically ventilated, but he has been on antibiotics and he really had to keep him alive. Occasionally, we developed a subdural hematoma, and this is the original picture of the patient. Nobody has ever recorded a fall before, and you see this is a chronic subdural hematoma, and there are just some fresh parts here of bleeding, what you can see. So actually, I knew the patient, I knew the family, and we decided not to have any life-prolonging therapy because this was not according to the will of the patient. So what we did, we transferred him to the palliative care unit. We did change the medication. We continued the antibiotic therapy, but he did get regular physiotherapy, and we did treat the delirium, what he had, maybe also according to the subdural hematoma. But, luckily, he didn't die on the palliative care unit, what we actually thought when he was on the intensive care unit. But the patient went home in January. And 4 years later, we had him in the hospital again because of apomorphine treatment, which worked very well. And 2 years later, after he was doing very well on the apomorphine pump, he died at home with home care palliative services. So what I want to show with that case is the disease trajectories in Parkinson patients are sometimes really difficult to define, even if we think that the patient is in the late stage or in the end stage of the disease. There are maybe some common symptoms, some signs, which make us clear that there is still the possibility to treat with medication. And delivering a Parkinson patient to the palliative care unit doesn't mean to have that the patient with life. Through communication, symptom control, care for the dying, but also, and this was lightened by the case I just presented, kind of a rehabilitation issue is also included in palliative care, especially when we talk about Parkinson syndromes and atypical Parkinsonian disorders. The symptoms in the last phase of life of our Parkinson patients are the dysarthria, the swallowing difficulties, rigidity, spasticity, sleep disturbances, delirium, and even epileptic seizure, which might not be very common knowledge. A shortness of breath, and I will tell about that one later, but also depression and anxiety. And pain is very common in the idiopathic Parkinson's disease. However, in some atypical Parkinsonian disorder, even there are severe dystonic movement abnormalities, pain is only rarely reported. We just have brought together the symptom control of the symptoms which are very common in the last phase. These are the swallowing difficulties, the rigidity, the epileptic seizures, the dyspnea, laryngospasm, the groaning, and vocal cord abduction paralysis, and the pneumonia. We will address some of these common symptoms in the following slides. So first we start with stiffness and rigidity in the advanced or in the late stage. So the main causes is to look whether the patient has too less fluids, because the intake of the fluids, of the swallowing problems and something like this might be difficult. So a very common cause of stiffness and rigidity is the hypoosmolarity. It could also be a difficult medication intake, and please always observe obstipation. Obstipation in the advanced phase is a really critical problem. We have seen some Parkinson patients who even have developed ileus or a subileus symptomatic because of obstipation. So according to these points, treatment should be on the first line of fluid substitution, or even consider a feeding tube placement. We will discuss this later on. Special medication is the roticotin patch. The advantage of the patch is that the patient doesn't have to swallow the medication, and also apomorphine, which can be given subcutaneously. You can start with a higher dose of apomorphine in the advanced stage of Parkinson's disease, because the normal side effects of the medication, like the severe vomiting, is critically diminished because the area postrema has changed. But also amantadine can be given in that phase intravenously or subcutaneously. Not all patients can cope up with subcutaneous amantadine infusion. So when you give the infusion, just give a small portion, maybe 10 to 20 milligrams subcutaneously before you start with the 200 milligrams subcutaneous infusion. What is also very helpful, especially in stiffness and rigidity, are benzodiazepines like midazolam and even morphine. Stiffness also might be related to a malignant dopaminergic withdrawal syndrome. So, when there are the swallowing difficulties, the patient doesn't get the medication or does not get the right amount of medication. So sometimes medication is missed, especially dopamine. And so they have a malignant dopaminergic withdrawal syndrome. And so you really have to pay attention to that one, especially when you see patients in a hospice or in a nursing home. I rather recommend to apply dopamine agonists or to give, L-Dopa in another preparation, like, the slow release preparation below the tongue. Yeah, I just have made this slide to show that almost all the medication we are using to treat Parkinson patients can be delivered via a feeding tube. They are even divisible, so you can really scratch the medication and give them in yogurt or anything else. But, I just want to say, if the patient has a feeding tube, a permanent feeding tube, or even you have to bring in a feeding tube for a certain time, you easily can apply most of the medication which is commonly used to treat the Parkinson's disease. Yeah, and there is something very interesting, because we have seen a stiff person-like syndrome in very advanced Parkinson patients. It's not only rigidity what they have, but they have stiffness, and kind of a stiffness which doesn't report to dopaminergic medication. It rather reports to benzodiazepine, like we are used in the stiff person syndrome. So if you have a patient with a Parkinson's disease in the advanced stage, or even at the end stage, try benzodiazepine like lorazepam or even midazolam subcutaneously. Could be easily applied subcutaneously in a very small dose. You can use 2.5 to 5 milligrams and even up to 10 and 20 milligrams over 24 hours. The drug treatment in the late phase, I just recommend to do this. On the late phase of the Parkinson's disease, you can use the slow release preparation of levodopa. You can use the amantadine. Can use the roticotin patch or the apomorphine subcutaneously, and as mentioned earlier, midazolam and also opioids. Yeah, delirium. Delirium is very often a critical cause in Parkinson's disease, and there are several causes why delirium can be occur in the Parkinson's disease. We do not have it only in the late phase. We sometimes have it very early on. So there are some very good publications out there about the psychosis spectrum of Parkinson's disease. And, people who already have hallucinations or delusions or something like this, it's more common to develop delirium, especially when they've been transferred from home to nursing home or to the hospital. There are several publications on delirium and Parkinson's disease. So we know that people with the Parkinson's disease are more common to develop a delirium than any other disease we are known. So important is the non-pharmacological treatment of delirium, and Professor Ebersbach, together with us, has published a paper on that one. What is very valuable are familial phone calls. So, when the patient in the hospital is getting or developing a delirium, he gets the phone call from a relative, which is very helpful in treating the delirium, and also provides stable and comfortable environment, having photos from his home, from his family, all these issues should really be respected. And please read the article for further details. The pharmacological treatment is even also very important. We all know that the only drug which has even been proven is clozapine. Quetiapine is still lacking some trials, and the effect of quetiapine in treating a Parkinson's delirium is somewhat critical. You know, some patients respond, some patients do not respond. We do not know how high we should escalate the dose and something like that. But also clonazepam or melatonin, especially when we have a disturbance of the sleep-wake cycle, are very effective in treating the delirium. Very often, Parkinson's delirium is additional, or the patient showing additional anxiety and something like this. And for that case, benzodiazepines are very helpful. Yeah, very common in hypoactive delirium. Patient lying in the bed, staring at you, or staring, you know, at the window or at the walls, and they do not even react. So the causes or the differential diagnosis are terminal agitation, dementia, depression, or the giving up syndrome. We have some patients who really want to have any kind of a medical or non-medical treatment anymore. So when you go there and visit them, they do not respond to any kind of a talk from you. So we also have the severe apathy, especially in atypical Parkinsonian disorder, the tauopathies, PSP and CBD. But also consider the intracerebral bleeding, as I mentioned, you know, in the case which I showed just at the beginning of the presentation. A subdural hematoma is very common, you know, and that doesn't have to be a history of frequent falls. And also what I mentioned, which is might not very well known, are epileptic seizures, and especially a status epilepticus in the advanced stage of Parkinson's disease. And also mentioned earlier, the pharmacological undertreatment might be a cause of hypoactive delirium. The treatment options. So what you have to try is to increase the dopaminergic therapy, as I mentioned earlier. And also you can use amantadine intravenously, you know. So it sounds a little bit crazy using amantadine in case of delirium, but we talk about the hyperactive delirium. And so the NMDA receptor agonist might play a role. So the infusion of amantadine is sometimes very helpful. And also what helps if the patient is still able to swallow is methylphenidate. You can start with a dose of 10 milligrams and escalate the dose to 20 milligrams very easily. So, as I mentioned earlier, the differential diagnosis, status epilepticus. So, the status epilepticus is very common in Parkinson's patients. So, Professor Feddersen from the Munich University has made a retrospective investigation in which he showed that people with the Parkinson's disease admitted on the people with status epilepticus admitted at our emergency department are very frequently, and with the status epilepticus in these 6 years, there have been 318 patients, and 20 of them have Parkinson's disease. So what I want to see is a de novo status epilepticus, even in patients, in Parkinson patients, where no epileptic seizure has been known before. A status epilepticus could be the first presenting symptom of epileptic seizures. And the status epilepticus, especially the non-convulsive status epilepticus, which is very common in Parkinson's disease, might look like an hypoactive delirium. Also, in this case, a trial with benzodiazepine might be helpful. Yeah, the breathing dysregulation. So, what has breathing to do with Parkinson's disease? The causes of breathing change in breathing pattern are the rigidity of the thoracic muscles, the pulmonary infections, as I mentioned. Also, the epileptic seizure could make a change in breathing pattern, frontal lobe changes, or also the subdural hematoma. Of course, medication, which might influence breathing pattern, like opioids, which I mentioned earlier, but also lymphedema due to a bowel obstipation. Yeah, the causes of death in patients with Parkinson's disease and progressive supranuclear palsy, which has been reported many years ago from Papadopoulos, and he showed that patients with PSP, the atypical Parkinsonian disorder, more common have respiratory related diseases as compared to Parkinson's patients. So this is also due to swallowing difficulties, which has always been known, but there is another cause which we only have recently shown. Don't be afraid because of that one. We have investigated breathing dysregulation compared between PD and PSP. And just look at that line here. The maximum ventilatory volume in PSP patient is significantly reduced as compared to PD patients. So that means a patient is not able to follow a regular breathing pattern. This is very interesting because the neurons regulating the breathing pattern are very close to the neurons who regulate the eye movement and who regulate also, the substantia nigra neurons. So there must be a common pathology also spreading to these neurons. And therefore, I really want to emphasize, that you look at the breathing pattern of these patients, because the patient who is not moving a lot, who doesn't realize that there's a change in the breathing pattern. But, if there is a pulmonary infection or a stress situation, the patient really realizes that there are some problems with breathing. So the symptom control in breathing, we have also the dyspnea, the laryngospasm, and the groaning. The groaning means the patient makes noises the patient is not able to talk anymore, but he makes noises like, ah. And that doesn't have actually something to do with, changes in the larynx or pharynx, it's just a frontal lobe change. And also for that one, tracheostomy is sometimes very helpful. I just want to mention the vocal cord abduction paralysis, which is very common in multiple system atrophy, but it is widely unknown. You see here a patient with multiple system atrophy, and she has a tracheostoma here. And as you can realize, she doesn't have a mechanical ventilation over her tracheostoma. It's only a tracheostomy. That's the daughter, and that's actually the nurse there. The vocal cord abduction paralysis often occurs in multiple system atrophy. And, for more than about 30 years already, a tracheostomy has been recommended in severe cases, and if the patient wants to have it. But, the patient, cannot decide on that one when the patient has not been thoroughly informed about that can be happen. So we have to know about the vocal cord abduction paralysis. The early symptoms are dyspnea, especially in nighttime, with pseudo-hypersalivation. And unfortunately, very often an emergency tracheostomy is performed in that cases. And as I mentioned earlier, with the patient, the continuous ventilation is most often not necessary. It's just, that the abduction of the vocal cord remains open. What you can is starting with small doses of opioid treatment at the night. Let's say, for example, 2 drops of the 2% solution at night are very helpful, especially when the patient goes to bed, to alleviate the symptoms which are associated with the vocal cord abduction paralysis. So this is an example of a patient with a PSP, and you can see he has a feeding tube. He's performing the clasp sign here, and he had an aspiration pneumonia. And after that one, during that one, he developed a vocal cord abduction paralysis. He was emergency tracheostomized. The patient, I have to say, the patient's will was to have every kind of life-extending therapy. So, and as you can see, there is no mechanical ventilation out there. It looks a little bit sad when you see the patient here in the bed, lying there, he's not able to do anything. And you really think, has this been the good decision to make this abduction paralysis? But as you can see, the wife was very happy that he survived the severe aspiration pneumonia and, the associated tracheostomy. So, and he was transferred to the palliative care unit. What we did was we did a rehabilitation program for him. And as you can see here, it was a very effective program. The patient has been able to walk assisted, and he was even barely able to walk unassisted. But happily and very surprisingly to us, he even has to be able to speak some words using the speaking canula of the tracheostomy, which hasn't been able before because of the frontal lobe dysfunction. He only had this groaning before, so he wasn't able to talk. Yeah. So the pseudo-hypersalivation is very important. As I mentioned also about this patient, for example, this is a patient with multiple system atrophy, and you can see she has the handkerchief here because the saliva is dropping out. She has the blepharospasm, and she also has kind of a dropped head syndrome because of the dystonia in the neck. So what we did in that case was we used botulinum toxin in the salivary glands, used botulinum toxin around the eyes and also in her neck. And you can see, you know, she's smiling now again. She can open her eyes and she's smiling without a handkerchief because, you know, an effective treatment of pseudo hypersalivation with botulinum toxin has a really significant effect on that symptom. And, you know, especially, I mean, this symptom is very, very stressful for the patient and the relatives because the patient is barely able to swallow, barely able to breathe with the superhallucination. And also, he avoids to go to public because it really doesn't look very good when you always work with the handkerchief before your mouth. Yeah. At the very end of the today's presentation, I want to open the discussion about feeding tube placement. I mean, there is, you know, only little data about feeding tube. We make a retrospective analysis, you know, in the year 2007 to 2009, we had 8 males and 2 females who did get a feeding tube placement. It's the reason is because first line, the females do not want to have life-prolonging therapy, including feeding tube placement, even if there are severe swallowing difficulties. And the second opinion is that, you know, the deceased males are more common treated at home. So, you know, the females wants to have anything to make the home care a little bit easier. An antibiotic treatment is much easier if patients have a feeding tube placement because especially also antibiotic treatment for, you know, urinary tract infections or something like that. A few basic ideas on eating and drinking. You know, there's no specific diet in Parkinson's disease. And the prevalence of being underweighted is very high, actually, 20% up to almost 40%, especially in the advanced phase. Every one of you knows a patient who is absolutely or almost normal eating, but he still loses some weight. So that sounds kind of a wasting syndrome, which is unfortunately not well understood in most cases, but it has an impact on, you know, motor function. Yeah, feeding tube placement or feeding on and food and fluids is not only about feeding and drinking. You know, since we are mammals and we are used to, you know, keep our babies cozy, warm, and safety by feeding them, you know, we really have a psychological background of feeding tube or feeding at all. So that means if I don't give someone food and fluids, I don't really care for him. So this is, you know, just to explain how psychological the issue of a feeding tube placement might be. So the general recommendation is, you know, to check the consistency of the food and having a good posture whereby eating and try to eat in the on face. And also, you know, for example, in PSP, the patients do overload their fork and their spoon. So they have a lot of food in the mouth and they always get the next portion again without really swallowing it. You really have to be careful for that one. And so this one has also been trained. And thicken fluids if necessary, or using adapted utensils like shown here. Katharina Lex has just looked whether there are any, you know, prospective trials or any trials which we could use to recommend the right time for feeding tube placement. However, we couldn't find any trials. So we were writing up some recommendation and published this in the British Journal of Nursing. So what is actually some bullet points? The discussion should not be with the patient alone. It always should be together with the family or one family member. And in Parkinson's disease, especially idiopathic Parkinson's disease, we have to discuss whether you only place a feeding tube, a gastric feeding tube, or already using a ileal part. So you know that in the advanced phase, you easily can apply duodopa, for example. And very important, the guy who inserts the feeding tube also has to control when is the time to stop artificial nutrition. Yeah, feeding tube, yes or no? Early discussion and advice from other patient groups. So bring the patient together with someone who already has a feeding tube, you know, and we really have to discuss very thoroughly in people with Parkinson's disease and dementia whether a feeding tube placement is really necessary or if the patient has any benefit from this feeding tube placement. If there is a feeding tube placement and you don't need them, don't remove it. It's not necessary. You can leave it, and you can even leave it without giving any fluid and foods over it. But sometimes, especially in the advanced stage, you can use it for the easy application of some special medication. And, it's absolutely necessary to applicate early on a feeding tube. We have experiences with feeding tube placement in later stages of the disease, or, if the patient already had this third aspiration pneumonia, the body weakness is increasing with the time of the disease, especially when the patient has already been suffered from severe pneumonia. So it's much more complicated, and there are much more complications of a feeding tube placement in the advanced stage. Yeah, and always, by all what we respect, we have to think about the relatives and the unit of care. The patient has a disease, but the partner or the family has really also to cope with the disease and all the decision made, in the temporal profile of the disease. So, the partner often has years of home nursing. She or he is partner and nurse, and they are neglecting their own needs. So, and obviously, sometimes there's a kind of a personal isolation because caring for the patient is very, very time-consuming. So you can't do much else. And we really have to take this into consideration in any kind of a treatment, change what we do or applicate. So I really want to thank my colleagues working together with me on some points in Salzburg, Munich, and here in Upper Bavaria and wonderful Paris. I have presented some of the research they have done, and I've mentioned them. Thank you for your attention, and now it's open to discussion.
Thank you very much, Stefan, for this very interesting and thought-provoking webinar on so many issues that in your presentations were presented very clearly, but in real life there are so many complications that and so many decisions made that the things that look clear in a presentation suddenly become very, very complex. And I just want to list some of things that you mentioned. So you said feeding tube, then tracheostomy, then botulinum treatment. And these are all, as I understand, life quality changing treatments as you presented it. On the other hand, we might have people who say that these are life-prolonging treatments. So what do they have to do with palliative care?
Yeah, as I mentioned earlier in one of my slides, palliative care, the main issue of palliative care is really to keep up with the quality of life, So, and I hope I made it clear that, feeding tube placement, but also tracheostomy is not recommended for any patient, but there are patients who really would have a benefit. And the story is, you have to have the experience as a physician, as a nurse, to really see whether the patient has a profit from the method. Because both of these methods are a little bit, invasive. They are recommending a small operation. It's not that difficult, actually, but at least it's an operation. And that's a difficult story because, and this is also the reason why we have these webinars, because the late stage or the advanced stage treatment is really underrepresented. Even, when we read about books or papers about that one. And as I mentioned, for tracheostomy, first paper out was 1992. This is, or 1996. So this is very long time, but still only a small amount of patients to get the tracheostomy because we are still lacking the knowledge. So there are some bullet points where you can make the decision whether the patient will have a profit. In first line, does the patient wants to have a feeding tube or a tracheostomy? The second line is always, does it make sense from a medical standpoint? So this is very important. So even if the patient wants to have one of these things, if it doesn't make sense, and it's not been able to, keep up with the quality of life or even increase the quality of life a little bit better, we really have to think whether we should applicate these methods. The third one is the surrounding able, and now here come the relatives or the unit of care, is the surrounding able to care for these methods we apply? It's normally not a point in feeding tube placement with tracheostomy. It's sometimes a little bit more complicated.
Yeah. So you are pointing out this very interesting issue, which has to do with also socioeconomic status of patients and their caregivers, which means that basically if you are maybe have a better education, we really don't know how it works, but at least we know that socioeconomic factors affect greatly what kind of access to treatments, rehabilitation and palliation patients have. And you work in Western Europe, in Southern Germany and in Austria, where people have very good access to all sorts of healthcare services, and even in a very short time they can visit physicians and things like that. But it is of course not like this in many other countries in Europe as well as in across the world. And then I think that in the Western hemisphere we come to the question that these treatments might be also very costly. And so how do you operate with this, and how do you think about socioeconomic aspects in your decision making, or is it not part of your daily tasks?
Yeah. Thank you for mentioning that. I think this is a very important task, when we talk about Europe or even, the entire world. Yes, we think about the socioeconomic status, and you're quite right. When the patient is an environment, where money doesn't, play a role, you can get anything for them, and they have a high quality of life, and many patients who are cared for in a surrounding where you have enough nurses and you quite at home, kind of a similar like in a small hospital, the quality of life is even increased in this one. However, sometimes, especially in Parkinson's disease, when we talk about the late stage or even the end stage, there is not so much money necessary. We see that in the advanced stage of these diseases, we can even reduce the pharmacological treatment to kind of a basic treatment, because the patient is barely able to walk and whatever, barely able to swallow. So, the care is increasing. And this is really important in our patient, So the only costly situation might be the feeding tube placement and, the artificial nutrition. As I mentioned earlier with the tracheostoma, you have the tracheostoma, you don't even need a ventilation in these patients. The care at home, when the stage is going from advanced to palliative care, it can't be done by a relative alone. Yeah? Because it's a very difficult care, and it's also for the body. It's very consuming. You need help. And this is very difficult even to get in our Western hemisphere, because that's very expensive. And that's also the time some people are transferred to a nursing home. And, as I mentioned earlier, some females even do deny life-prolonging therapy at that point, because they don't want to be a burden for their family. And burden does also mean a financial burden.
Yes, we have heard it from other participants in our webinars as well, that when the feeling comes that you're burdened to your family, then I think David Oliver mentioned that they put me in the shed in the garden and so that I don't cause any costs and any burden to you, that the place of death doesn't really matter that much as we try to sometimes stress it when we speak about palliative care. So it's the care that is important, but still now I want to ask about two things. One is the pain, because for me it is it was kind of a revelation to hear about even that Parkinson's patients at the end stage, the pain is one of the main symptoms, really. So So what are your experiences, and how you mentioned that it is one of the symptoms? What should other professionals know about this pain at the end stage? And you had a list of medication, but you had also non-pharmacological suggestions there. So maybe you can point out some things that have worked in your practice very well.
Yeah. I mean, actually, pain, I didn't mention that one because it's not very common in the late stage. Interestingly, pain in Parkinsonism is most likely a musculoskeletal pain, and the pain in the end stage is most often related to hypoactivity. So, patient lying in the bed, being in the wheelchair, and she or he doesn't have a really good muscle mass. So it's the pain of the joints very often, or the bones. And, having a regular physiotherapy, even in patients who are lying in the bed, can significantly reduce the pain. Very interesting, and as I mentioned during my presentation, like in corticobasal degeneration or PSP, where we have this tauopathy, where we have severe dystonia, the patient often doesn't have really pain. It looks really very critically, and also the frequent falls what they have, interesting, it's not painful. So, seeing a patient with dystonia, seeing a patient in a, weird position in the bed doesn't mean the patient has pain. It's more the musculoskeletal pain. And unfortunately, opioids are not very effective to treat that pain. Non-steroidal antiphlogistics are very effective in regular physiotherapy. I mean, this is what I recommend when a patient is lying in the bed, to have a regular movement of the joints, that can significantly alleviate the pain. And that's most important,
Yeah, so this again points out the importance of these allied professionals who can really help patients in their conditions. So it's not only medication. So are there some aspects about like polypharmacy and polymedication as well? Because of course, in the ideal world, you would have only Parkinson's disease, but we know that people have multiple conditions and it all comes together. So is there something you would like to point out from this?
Yeah, polypharmacy is actually very common, especially the treatment of Parkinson patients. I mean, there is, the story when the patient develops Parkinson syndrome, you treat with one or two medications, and during the course of the disease, you have sometimes 4, medication at the same time, only to treat the Parkinson symptoms, and then comes, might be diabetes and hypotonia and something like that. So what we experience is, by disease progression, we really can reduce the treatment for the Parkinson patients. Being always on, let's say, on a continuous treatment means that some of these patients run very fine with levodopa only in the advanced stage, and having some treatment for the hallucinations or something like this. We also have made the experience, when they are bedridden, when they are in the wheelchair, so the hypertonic treatment could be reduced, and when we have differences, in the intake of food, we really have to consider whether an anti-diabetic treatment should be continued or something like that. So, yeah, we frequently reduce not only the palliative, but in the advanced stage, the medication. Because the polypharmacy in Parkinson's disease is more prone, to be a part of developing hallucinations, So you really have to be very careful. And the problem is, this is the patient in the advanced or the late stage, we do not see in our hospitals, we do not see them in our private practice, in our things. They stay at home, or they go to a nursing home, and nothing has changed there for years, unfortunately. So then we see the patient in the first crisis, when he has, many, many medications, but isn't able to have a fluid intake, which is necessary when you have many medications. So then they are transferred to the hospital. But sometimes at that point, it's already too late to make significant changes so that the patient has a really profit of it.
Mm-hmm. Yeah. So it's there is still in terms of how healthcare is provided, there are still gaps that people fall into, and it leads to the personal struggles of caregivers very often. So if you have someone hallucinating the all night long, and so it means for years you cannot sleep really during the nighttime, and what then happens if some crisis comes? And we had it also when we spoke about advanced care planning, that why should anyone do the advanced care planning? So that usually this is, then people start to think about this when the crisis is already there, and then it might be too late. And now we come to this, that when people then come from their homes and they are picked up by emergency car, and they end at the emergency department where people are not familiar with their history and with their treatments. And so then very often something can happen, some kind of life-prolonging treatment can be presented out of lack of knowledge, for example. And so how often this happens in Parkinson's patients, and what kind of dangers are connected to this kind of procedures?
Well, as I mentioned in my presentation, the dopaminergic withdrawal syndrome, a sudden change in a significant dopaminergic medication, even in the advanced stage, can have severe side effects, from stiffness or, most common, they start with hallucinations. And that could be dangerous. This is a life-threatening event when you don't have the knowledge how to change the medication. A patient can simply die from it, So, and therefore, you have to be very careful, and you have to have a great experience what kind of medication could be withdrawn a little bit faster and which has to be continued, and withdrawn a little bit later. And very often it happens in the hospital, as I mentioned also in the case, there is a change of medication pretty quickly, and so the patient suffers at least from delirium or hallucinations. Yeah? But it can be as harmful as a patient might die.
Mm-hmm. Yeah, so this is also a question about education. And this is my final question, even though I would have several other questions as well. But so how do we... what do we have to do? So this project is very much education oriented, and we have understood via our conversations that there is a serious lack of education in terms of to make good decisions, and one part of this is also communicating with patients. But how do we make this kind of information that you just presented us, which is very new, very innovative, many people don't know about it, available to more and more people, so that we would avoid this kind of critical situations and crisis in healthcare and in families, of course, as well, that happen then.
Right, of course. I mean, you mentioned it, we have to have more education on that one, I mean, luckily, now many Parkinson's associations around the world have realized that the advanced or late stage is very important, and there are different treatment options in that case. So, on very, very many congresses, we are eager to speak about that one. But that's not enough, So what we have to do is have an education also by the students, so they know Parkinson's treatment is very important. But especially, the specialists and also the nurses should get more education that what can we do in the advanced stage? What can we do? What should we avoid? I think there are some people out there, who are treating Parkinson patients for decades, and they still also have the knowledge, but it's not brought to the right person.
So thank you, Stefan, for your presentation and for this very nice communication. And maybe last word now to Michaela to wrap up this webinar.
Thank you so much for your presentation. It was very informative, and it will be very, very useful for all the healthcare professionals that are approaching also late stage PD. So thank you for your presentation, and thank you for everybody for joining us.